So hello to all of you. Hello to all of you and welcome to the YouTube session for the anatomy in which we will be discussing the 25 most important questions. And good evening to all of you. Welcome to all of you. So before we start with the discussion of 25 questions, a point which I would like to talk is that all of you must be preparing very well at this point of time, and all of you must be putting so much of hard work. And now at this time, what is more important for you is two things. One thing is persistence. You have to persist in what you are doing. You cannot waste any day. Persistence मतलब आपको चीज़ों में persist करना है. जो आपने शेड्यूल सोचा है, जो भी आपने पढ़ना है, जो भी आपको सब्जेक्ट्स पढ़ने हैं, उसमें आपको persist करना है. उसमें आपको बीच में कहीं पर भी ब्रेक नहीं लाना है. You have to persist throughout this period of time. Second most important point is positivity. So these 2 points are very important, your persistence and your positivity. Positivity means that you now, whatever days are left, you have to be positive in this period of time. So you have almost, you can say 29 or 30 days left. You have to be positive during this, because a lot of times what happens now, we are having a lot of doubts in our mind, or like a lot of things come in our mind when we are doing the revision, then and we are not able to answer few questions. So always remember, that day when you started the preparation, you are much better. You are at a much better situation or a point now. So when you started your preparation, you had no idea about that how to solve the MCQ, and you had very minimal knowledge. But now you are having you are filled with all the knowledge. You are having a lot of knowledge. You are able to attempt so many questions, and now you are sitting for the most important questions also. So that means you have attained a very high level. So you should appreciate for yourself for that and be positive. Always think that yes, I will be able to cross this exam, I will be able to pass this exam. And whatever you will tell your mind, the mind will work according to that. So keep working hard, you can get anything that you want. So now let us start with the MCQs. Okay, now this is the first question, and I want everybody of you who has joined the session that please try to answer the question. Okay, please try to answer the question, and then after that we will discuss this. Okay, now the question is identify the arrow marked structure. Now when you see this arrow marked structure, you have to choose between what A is lateral ventricle, B is fornix, C is thalamus, and the D is corpus callosum. So what is this section? I will just give you a hint that it is a coronal section. A coronal section of the brain, and this is a cadaveric section. So this is a cadaveric coronal section of the brain. Okay, now let us see what is it. Now this over here, because I think that from here it is a slight delay at your side. So let us answer this question over here. Now when you see this question, what is this? This structure is actually fornix. Okay, this structure is the fornix. And now when you seeing this coronal section over here, so what is this? I will just mention over here that this is the coronal section. And when you are talking about the coronal section of the brain, what other structures you see over here? So you already know that whenever we are talking about the nucleus, one big oval shaped nucleus over here is thalamus. Okay, this is the thalamus. Then on the lateral side, when you see this triangular nucleus, what is this triangular nucleus? This is lentiform nucleus. This is a lentiform nucleus, and another nucleus which is present over here, a small oval shaped nucleus which is present over here. This is what? This is the caudate nucleus. Okay, this is the caudate nucleus. This is the caudate nucleus. Now when you see the area which is between these nucleus, this area, so we very well know that this V-shaped area which is between this is internal capsule. Okay, this area is the internal capsule. Now the connecting fibers which is between the right and the left cerebral hemispheres, what is this structure? This is corpus callosum. Okay, this is the corpus callosum. Now when you say that what is this triangular area, the triangular area which is near the caudate nucleus, this is the location of lateral ventricle. And when you see the space which is between the two thalamus, the ventricle which is between the two thalamus is what? It is the third ventricle. Okay, I will put the arrow over here that this is the third ventricle. So now all these structures are there. If you see on the lateral side, a deep depression is there. What is it? It is the lateral sulcus. Okay, it is the lateral sulcus, and whatever area is surrounding this lateral sulcus over here, what is this? This is insula. So we have identified all the structures over here, and now when we are talking about the corpus callosum, so from the corpus callosum, some structure, it looks like, I will just zoom it over here for you. It looks like a structure is hanging below from that, and now this lowermost structure is what, which we have labeled over here as the fornix. So the answer of this question is what? B. The answer of this question is B, which is fornix. Okay, answer of this question is fornix. Yes. Just give me a minute over here. Just give me a minute over here. Right, so this is the fornix, and let us see this one more section. This is the same section and all the labeled structures over here. So what we have mentioned is that this is the corpus callosum, right? This is the corpus callosum, this connecting structure, and below it, this component which is present over here. Below it, this component which is present over here is what? It is the fornix, right? So this is what? This is a coronal section, and we have identified all the structures. Now over here, I'm going to mention one more structure which you should be knowing in this coronal section. When you see the thalamus, okay, when you see the thalamus over here, this is a location of the thalamus. Now just after that, this is the area where the midbrain is present, because this is a coronal section like this. So cerebrum, and then we are having the midbrain, and then you are having lower side pons. This is the pons. So this is the area where the midbrain is present. Okay, this is the area midbrain, and in the area of the midbrain, when you see this small round structure, what is this? Just below the thalamus, you see some small round structure. This is the location of red nucleus, and further below that, you see a pigmented area. Okay, when you see this pigmented area at this location, now what is this? This is substantia nigra. So you should be able to identify these two more structures over here, right? So now we have identified fornix. Okay, we have identified fornix. One more thing I'm going to mention about the fornix is its Papez circuit. Now what is this? In this, what is important for you is that when we are talking about this fornix, okay, you should be knowing that from where it is bringing the fibers and where it is taking the fibers to. Means kahan se fibers aa rahe ho aur kahan ja rahe hai, ye ek aapko idea hona chahiye. Now what is this? It is bringing the fibers from hippocampus. Okay, now when the fibers are going from hippocampus to the mammillary body, the fibers which are present are given the term as fornix. So the connection between the two is fornix. Now from the mammillary body, the further fibers, they go to thalamus, and in the thalamus also, which nucleus? It is a specifically anterior nucleus of thalamus. So these three structures are very, very important for you to know, that hippocampus, then through the via the fornix, mammillary body, and via after that it is going to the thalamus. Specifically which nucleus? Anterior nucleus, and this is what this tract is known as mammillothalamic tract. Further it is going to the cingulate gyrus, and then further the fibers are coming towards the hippocampus. But these three structures which I have ticked over here, they are very, very important, and recently the question has been asked in INI-CT only. They have asked you about this, which nucleus of thalamus the fornix is carrying fibers towards, which nucleus of thalamus? So the answer was anterior nucleus. So now we know, yes, very correct, it was substantia nigra. So the answer of this question is fornix. Very, very correct. Now let us see the second question. Now try to answer this second question over here. Now this is a question on mediastinum. Yes, very, very correct. It was arising from hippocampus and going to mammillary body, and now you also know further where it is going. Where it is going to the anterior nucleus of thalamus. Specifically which nucleus? Anterior nucleus, right? Okay. So let us see this. Now this is again a cadaveric image, and let me tell you the orientation. This is a lateral view of the thorax, and in the lateral view of thorax, one lung has been removed. And when you see this image, you are able to see beautifully this heart and a big structure which is going like this, which you know is aorta. Okay, this is the arch of aorta, and it is further going over here. This is the descending aorta. Behind you are having the vertebral column. Now when you see the arrow over here, so first of all let me write over here that what is this? This is the heart. Okay, this is the heart. Yes, very correct. I can see that you are trying to answer it and you are answering it perfectly correct. So what is it? Whenever you are reading the question, so when you see this image, first of all your mind is like, oh my god, the cadaveric image is there, so your whole mind is focused on that. So whenever you are attempting the question, you have to be calm and you have to read the question carefully. Whenever you are reading the question, you have to see what they are asking. And yes, very correct, you are all answering it very correct. Now the question is, either they say you among the following what is the correct statement, or they will say you all the statements are correct except, or they can say like I have written over here, which is incorrect statement. Okay, so the question is incorrect. So this is very important to observe this word correct, incorrect, except, or if it is written not, because that will completely change the answer. So we have to look for the incorrect statement. Now first of all let us identify what is A. Now when you see this A structure, what is this? This is phrenic nerve. Okay, this is a nerve which is running from the superior mediastinum towards the middle mediastinum where the heart is present. So the nerve which is adjacent to the heart, which nerve is this? Yes, this is phrenic nerve. And when we talk about the phrenic nerve, we know very well it is having the root values C3, C4, C5. It is supplying what? Yes, it supplies diaphragm. Okay, it supplies the diaphragm. And now when you talk about the next structure, what is the next structure over here? This is also a nerve which is running in this way. Okay, so let me show you again. Now you can see some nerve is going like this, and further it is running in this way. Now what is this nerve? This is vagus nerve. This is vagus nerve. So whenever you are identifying this image is very important. Lateral aspect of mediastinum with one lung removed. When you see any nerve on the anterior side which is adjacent to heart, बिल्कुल heart के बगल में चल रही है, साथ में चल रही है, वो है phrenic. So the nerve which is running adjacent to the heart is phrenic, and it is where it is on the anterior side of the image. And when you go towards the posterior side of the image, this is vagus, and specifically this is present where? It is present just behind this hilum area. Now when you see this area over here, a lot of cut sections are there which is representing the hilum area, the hilum of this lung, and behind the hilum the nerve which is running like this is vagus. So anterior to it you are having phrenic, posterior to it you are having vagus, and if you go more posteriorly, what do you see? One more nerve is present over here which is having a beaded appearance. And now whenever we are talking about this structure, we say what is this? This is sympathetic trunk. Okay, this is the sympathetic trunk which is having a beaded appearance on the most posterior side. So now we have identified all the structures. Now let us see. Yes, A structure is vagus, and when you talk about the vagus, yes, its root value of course is C3, C4, C5. Injury to A means phrenic nerve, leads to shortness of breath. Yes, because A phrenic nerve is supplying the diaphragm, and whenever it is injured, whenever the nerve is injured, it leads to the paralysis of diaphragm, and due to this a very typical symptom appears, shortness of breath. So this is also correct. Structure B is vagus. Okay, this is the vagus. This is the vagus. A was phrenic, B was vagus. So vagus supplies diaphragm. No, this is not correct. It is a phrenic nerve. That means the option A is actually supplying, this is option A which supplies the diaphragm. D says structure B means vagus nerve passes through what? Esophageal opening of diaphragm. Yes, it is correct, because vagus nerve travels along with the esophagus through the esophageal opening. So the esophageal opening giving passage to esophagus, vagus nerve. Along with that, the esophageal branches of left gastric artery. And if I say what about the phrenic nerve? So for the phrenic nerve, the right phrenic nerve passes through vena cava opening. Okay, it is passing through vena cava opening along with the inferior vena cava. So all these are the structures which are passing through the major openings of the diaphragm. And very, very important, you know, aortic opening, which you should be knowing also, is aorta. The structures passing through it is aorta, azygous vein, and the thoracic duct, right? So over here now we have seen that vagus is passing through esophageal opening, which is very, very correct. So the answer of this question will be what? The answer of this question is C, because this is incorrect statement, right? This is the answer. Now let us move on to the next question. Yes, very correct, dear. The esophagus, vagus, and the left gastric artery, very correct. So, so what do you observe in this is that you have all the knowledge and there are multiple things which are tested in one question. So you have to apply all your knowledge in whatever question you are getting. Like in the previous question, we were checking your image-based capability, plus we were checking that do you know the openings of the diaphragm, do you know the details of the phrenic nerve. So a lot of things, multiple things were tested. Now let us see this question over here. Try to answer this question. Okay, let us see this question over here. Which structure forms superior boundary of arrow mark structure? So I'm just zooming it for you, the arrow mark structure. And yes, and when you see this image, what is this? This is actually a sagittal section of abdomen. And you can see over here, what you can see over here is this is the liver. Then you can see this is the stomach. And there is the arrow. Arrow is, yes, very correct. The arrow is on a small, you know, circular opening which has been shown. It is between what? Liver and the stomach. So this is, you know, almost a very, like a location you can see is of what? Epiploic foramen. So very, very correct. I can see a lot of students are answering over here. Yes, very correct. So we are actually talking about what? Epiploic foramen. The complete name is the epiploic foramen of Winslow. So now when we are talking about this epiploic foramen, this is the image showing the location of the epiploic foramen, and it is what? It is a communication between the greater sac and the lesser sac. So when you see this blue colored area, this is what? Lesser sac behind the stomach, and the rest of the area is greater sac. These are the two parts of peritoneal cavities which are communicating each other at epiploic foramen. And when you see this image, now this is the image which is actually telling you the exact location of the epiploic foramen. So let us see this image. This is the location of epiploic foramen. Above you are having the liver, below you are having the duodenum. Which part? First part of duodenum. So you can see the stomach is continuing into duodenum. So that is why, of course, it is the first part of the duodenum. So above you are having liver. This is clear with this image. Lower you are having what? Clear with the image. First part of duodenum. Next thing is you are having some omentum which is present over here. It is a omentum which is from the stomach to the lesser, from the liver to the lesser curvature of stomach. So what is this? This is lesser omentum. So it has been shown like this over here, that this omentum which is present over here is what? It is the lesser omentum, and it is present where? It is on the anterior side. So when we are talking about the boundaries of epiploic foramen, we can see over here schematically, first of all, let us see superior side. Superior side, we know liver. So for the liver, caudate lobe of the liver, or specifically the caudate process, this is, of course, a part of the liver, and the liver is on the superior side. So when you see the caudate lobe, you know it is a part of liver. Superior boundary. Inferior boundary, first part of duodenum. Anterior side what? As I mentioned over here, lesser omentum. And the lesser omentum, the free margin of lesser omentum is having what? It is having portal triad. Okay, it is having portal triad. Yes, very correct. So portal triad is what? Portal triad is a combination of hepatic artery, bile duct, and the portal vein. These three together are known as portal triad. And another relation over here is posterior side. So posterior to it, behind it, we are having inferior vena cava, and also we say T12 vertebra. Just behind it, we are having the T12 vertebra. So these are the relations of epiploic foramen, and therefore now when we see this question over here, what structure forms superior boundary of arrow marked area which is epiploic foramen? So you very well know it is caudate lobe. So when you see the epiphyseal foramen, of course you say above liver, so caudate lobe answer. The duodenum is on inferior side, IVC is on posterior side, and lesser omentum is on anterior side. Okay, now let us go to the next question. Now this is a very important question, and all of you should be able to answer it. When you see this image, you very well know that this is what ear ossicles. And in the ear ossicles, we know this is malleus, incus and stapes. So that means we are talking about the joints between the ear ossicles. It is the joints between the ear ossicles. Now when you see this joint over here, so try to answer it. Till then we are discussing few points over here. When I say what is this joint, it is a joint between malleus and incus, which is known as incudomalleolar joint, right? And now we say one more joint is over here. Yes, very correct. I can see a lot of you are answering this question. CD, yes, CD. Now this is a confusion which occurs over here, C or D. Now the second joint which you see is between the incus and stapes, which is known as incudostapedial joint. And now when you are talking about the joint over here, first between malleus and incus, this joint is of saddle variety. It is of the saddle variety of synovial joint. Okay, so now you can say what will be the answer? Yes, very correct. Now what will be the answer? The answer will be, it will be D. The answer will be D. It is a saddle variety of the joint, not ball and socket. It is a saddle variety of the joint, and this is a very important point which I can see a lot of students are doing it wrong. So this is a point at which this is a point where you will correct yourself, and from today you will be answering it correctly, that between the malleus and incus it is saddle. And when you say incus and stapes, between these two we are having ball and socket. It is a ball and socket variety of synovial joint. So therefore the answer of this question will be what? It will be saddle. Okay, the answer is D. Okay, answer is D. It is saddle variety. So very important, when you say first joint is saddle, and the another one, second joint between incus and stapes, it is ball and socket. Now over here I will mention one more thing. Ball and socket is a very common variety, and not common variety, it is a very easy one which we all know is your shoulder joint and the hip joint. Okay, that everybody knows. But the joint in which everybody goes wrong is this one. So that is why please remember this one, very important. And over here I will mention one more joint. Okay, one more joint I will mention. So this we have discussed. We know the answer is saddle. Now one more extra question I am going to give you. One more extra question on the joints I am going to give you. Try to answer it. One more joint I have mentioned over here, which is very important and a highly expected question. Now when you see this image, try to answer that this is which variety of joint. Now when you see this image, you perfectly know that this is the image of foot. Okay, these are the bones of the foot, and let us identify the bones of the foot. This one is talus. Okay, this one is talus. This one is calcaneum, and this bone which is in front of talus is what? It is navicular. Okay, so this is the medial view of the foot, and when you see the bones over here, you know that it is talus, navicular and the calcaneum. So now the joint which is between the three, this joint, this is which joint? So the arrow is on talo-calcaneo-navicular joint. Okay, so yes, very correct. I can see a lot of you are trying to answer this, and you are saying B. Okay. So talo-calcaneo-navicular joint. So now when we are talking about this talo-calcaneo-navicular joint, this is a joint which a lot of students, they ignore Ignore means that whenever they are memorizing, they just put it on the side, ki, oh, this looks like very different type of joint or difficult, so they ignore it. But this is a very, very important variety of the joint, and you should be able to answer it. What is the variety? Yes, the answer of this question is, it is ball and socket. So ball and socket, two joints which are very, very important, which you all of you should be knowing very well, is one is between ear ossicles. Which one? Incus and stapes. That is a ball and socket. Another we mentioned over here, talocalcaneonavicular joint. And when you are talking about any joint, you should be able to identify in the image. So very, very correct, all of you, very, very correct. It is ball and socket. Okay, it is a ball and socket variety. So the answer over here, this is a ball and socket variety. And over here, what is actually there is, this is the talus. The head of talus is acting as a ball type of surface, and the socket is formed by navicular, and along with the navicular, this calcaneum part. They form the socket, and over here there is a ligament which connects the two and contributes in the formation of the socket. So this ligament we know very well is the spring ligament. So this is how it is forming the ball and socket variety. So आज मुश्किल है, कल थोड़ा बेहतर होगा. ये तो सही बात है, आज तो काफ़ी मुश्किल लग रहा है, ऐसा लग रहा है कि ओहो ये तो लाइफ ही पता नहीं क्या हो गई है. तो आज मुश्किल है, थोड़ा नहीं बहुत ज़्यादा मुश्किल है, कल थोड़ा बेहतर होगा. बस उम्मीद मत छोड़ना, भविष्य ज़रूर बेहतरीन होगा. So always remember that it may look like a very difficult situation to you at this present time, or at this period of time. You must be feeling, oh my God, what is this? What is this life? But let me tell you that yes, in the future the things will change and it will be in your favor. So just keep going on. Be like in the starting of the session I said persist. So two points very important is your persistence and your positivity, and that will take it to the heights. That will take you to the success, definitely, because all of you are putting the hard work, but these 2 points are really, really important at this moment of time. Okay, now let us see this question over here. Yes, very correct. Yeah, all of you are able to identify the bones, the talus. Okay, सही बात है, एवरीडे मुश्किल है, काफ़ी मुश्किल है. अभी तो ऐसा लग रहा होगा ये बहुत ही मुश्किल है, लेकिन जैसे ही एग्ज़ाम क्लियर हो जाता है ना, तब लगता है कि अरे अब तो कुछ करने के लिए है ही नहीं, एकदम खाली हो जाते हैं. तो वो मोमेंट एंजॉय करना है ना, तो थोड़ा सा अभी ज़्यादा एफर्ट डाल दो. वो मोमेंट हमें एंजॉय करना है, जब हमें लगेगा अरे यार अब तो कुछ है ही नहीं करने के लिए, एकदम खाली है. वो मोमेंट आना चाहिए. सो जस्ट पुट दैट एफर्ट एट दिस पॉइंट ऑफ टाइम. गिव एक्स्ट्रा एफर्ट्स एट दिस टाइम. Whatever you are thinking that I'm putting the efforts, oh my God, I'm so tired. So don't be tired. Give more efforts, because if you clear the exam, the destiny will change, the things will change completely. Okay, now let us see if you are able to answer this question over here. Yes, I can see a lot of students are you are trying to answer B, D, C, A. Now, when you are reading the question, like I get a point from all the students is that, ma'am, English has been twisted. So this is a twist in that English. When you are seeing the question, how to understand? Just see, each word matters. Now, what is happening? Stab injury. Where is the stab injury? The location is where? Lateral aspect of what? Lateral aspect of dorsal part of spinal cord. Means what is it saying? That on the dorsal part of the spinal cord, the injury is from its lateral side. So lateral aspect of dorsal part. Okay, it is not saying lateral part of spinal cord. ये lateral part of spinal cord नहीं कह रहे हैं, ये कह रहे हैं dorsal part of spinal cord है. Dorsal मतलब posterior, और उसके भी lateral side पे injury है, right? So lateral aspect of what? Dorsal part means posterior part of spinal cord. Where? In the neck region. It is in the neck region. So what is going to happen over here? What is most likely to be seen? So let us first of all discuss, and I can see a lot of you are trying to answer it very well. First of all, let us discuss over here. When you see the transverse section of spinal cord, this is the anterior side and this is the posterior side. And when you see the posterior side on the dorsal aspect of brainstem, on the dorsal aspect of spinal cord, this whole area is occupied by what? Yes, this is occupied by dorsal column. This is occupied by dorsal column. So now what we are saying is that injury is at which point? The injury is towards the dorsal part of spinal cord, but on lateral aspect, means this is the location of the injury. I've put the arrow over here. Now when you are talking about the dorsal column, we very well know that the dorsal column is having two components, nucleus, it is fasciculus cuneatus and fasciculus gracilis. Now whenever you are talking about this fasciculus cuneatus, what we say is it is carrying the fibers, from upper part of body, okay. And when you are talking about fasciculus gracilis, for this we remember over here that it is carrying the fibers from lower part of body. Fine. And these two components together, they form the dorsal column. So this we very well know that these two components form the dorsal column. And now when you see this image, the dorsal column is having two components. One is this component and another is this component. So what we say is this is the location of fasciculus gracilis. So fasciculus gracilis location is on more medial side. And when you say what is this? This is the location of fasciculus cuneatus. The fasciculus cuneatus is on the lateral side. So in the dorsal column also formed by two components, gracilis is on medial side and the cuneatus is on the lateral side. And now you understand that if we are saying that injury is on lateral aspect of this dorsal column, means the injury is to fasciculus cuneatus, means upper part, the symptom will be where? Upper part of the body. Fine, this is fine. So symptom will be in the upper part of the body. So this is the location of injury. Now let us come back and try to answer it. Whenever you are saying the dorsal column is gone, so what we say is that because the dorsal column is gone, where the injury is at the level of what? Neck area. But the crossing of fibers occur where? The crossing of fibers occur in the medulla. So whenever we are talking about the crossing of the fibers, we say the crossing of fibers, they occur in the medulla. So we know the rule for the crossing of fibers. If the injury is below the level of crossing, symptom is ipsilateral. And if the injury is above the level of crossing, the symptoms will become contralateral. And now what we are saying is that the injury is in spinal cord, specifically in the neck area. Means the injury is over here. So the symptom will be on the same side. Okay, same side symptom will be there, ipsilateral. Because it is below the level of crossing, the level of crossing is at the medulla. So now what we have understood is that, first thing we have understood that the fasciculus cuneatus is gone, due to which the symptom will be seen in the upper part of the body, means arm area. So first of all, we have excluded the C and D option. We have to choose between A and B option. Another thing, according to the crossing of fibers, what we have mentioned is the symptom will be on the same side, means ipsilateral side. Because the lesion is below the level of crossing, means in the spinal cord and where? Of course, in the neck area. So spinal cord, so ipsilateral loss of proprioception. Now it can be loss of proprioception, it can be loss of fine touch, it can be loss of vibration. So any of the sensations carried by the dorsal column can be gone. But what is important for you is to decide between this and then to decide between ipsilateral and contralateral. So now we have understood that why the answer over here is this one. So the answer of this question, now we have understood, is yes, very correct. The answer of this question is A. So when we are talking about this question, ipsilateral loss of proprioception, where? In the arm area. So I hope that you have understood that how to approach the question, because that really matters. If you know the basic concept of that topic, you are able to approach the question. Plus, very important, it is also very important to understand the English of the question, that what they're asking and how to analyze that component, how to analyze that English. Okay, now coming to this next question, you can see over here. This is a very commonly asked question, you know very well. When you see this arrow, everybody will be able to answer that what is this? Yes, this is pterion. And this is a very, very frequently asked question, but now they are asking a question a level up. Earlier they were asking only this image and they said identify pterion. But now what is present deep to it? So what is present deep to it? Watch the words in the option whenever you are answering, because I can see that you are answering A. Watch the words which are mentioned. Like when you say in English twisted. So slight difference in the nomenclature. Now when you are talking about, let me tell you, because everybody of you are marking A. Deep to the pterion, what is present? Just write the answer. Write the answer. Don't write A. Write what is present deep to pterion. What do you say? Middle meningeal artery. Of course, you say yes, ma'am, middle meningeal artery. But do you see that it is the same word? It is not middle meningeal artery. It is accessory meningeal artery. There are two arteries. These are two different arteries. They are not the same arteries. So A option is not correct actually. It is not correct. So I've given you the hint that A option is not correct. It is actually the middle meningeal artery, and middle meningeal and this accessory meningeal, they are two separate arteries, and this is the twist over here. This is the trick over here. You can see this twist over here that you were thinking you saw at A, accessory, and you quickly marked it A. It is what? Middle meningeal. All of you are knowing middle meningeal, but still we marked A because we saw this word meningeal, but it is not the answer, so I'm just crossing it. What else? Central sulcus, stem of lateral sulcus, medial longitudinal fissure. So now what can be the answer? You have to tell me what can be the answer. Yes, very, very correct. It is stem of lateral sulcus. The lateral sulcus, also known as Sylvian fissure. So lateral sulcus or Sylvian fissure, and to be more specific, it is the stem of lateral sulcus. This is the answer over here. Everybody has been always answering middle meningeal artery, and we also know that the rupture of the middle meningeal artery leads to extradural hemorrhage, right? And another thing which you should be knowing apart from this is, so middle meningeal artery we very well know, and now we know middle meningeal artery, and we say specifically its anterior division. Okay, specifically the anterior division, or it is also termed as frontal or anterior division. Frontal or anterior division means what? That when we are talking about this middle meningeal artery, it is running like this, one branch going in this way, another branch going like this. So deep to the pterion, what you see, its anterior component is coming deep to it. So I mentioned over here specifically which division, anterior division or frontal. Frontal because it is going towards the frontal side. So now you know in detail. Next thing passing through deep to it is brain. Brain, cerebrum. Which part of cerebrum? In the cerebral hemisphere, it is a lateral sulcus. It is a lateral sulcus, and sometimes they mention you the word stem of lateral sulcus. So don't be confused. Stem means the main part of lateral sulcus. ठीक है? Stem कोई अलग से word नहीं है. Stem मतलब main part. Like when you have the plant, na, plant is having the main stem and then the leaves are there. So similarly, this is the main part of lateral sulcus. So these are the two very, very important structures. Very, very important structures. And middle meningeal artery, everybody knows. Please, please, please remember today only, remember stem of lateral sulcus. These two very important structures. Yes. Thank you. Thank you. So the answer is stem of lateral sulcus. Okay, now let us try to answer this question. Identify the arrow mark structure. I will zoom it for you so that you are able to see the image. Okay, now when you see this image over here, what do you see? This is a thoracic section, okay, the transverse section of thorax. And when you are seeing the transverse section of thorax, we are having two sections which are important in that. One section is the one which is passing through the heart, and in that usually the question is asked on descending aorta, or they put the arrow on the left atrium. But now this section is what? It is a transverse section above the heart. So that is why you are not able to see the heart section in this image. You are able to see all vessels. All vessels are present. So this is, we say almost this section is at the level of T4, which is above the heart, and a very specific point. Yes, very correct. CD, very correct. So the most specific point about this section is that you always see two big circles. And whenever you are seeing these two big circles, this is a section above the heart, which is at the level of T4. And what is this? Both are the sections of aorta. So let us first of all decide what is the anterior and the posterior side of image. This is the anterior and posterior side of image. Posterior side, you are able to see this vertebra, right? It is having these structure, the processes. Anterior side, you are able to see the flat bone, which is sternum. Now when you see the vertebra, now over here in the vertebra, what do you see is some structure is present over here. What is this? Yes, this is the spinal cord which is present within the vertebral column. So when you see the vertebra over here, you are able to see the spinal cord. And now the rule over here is that whenever you identify the vertebra, you know it is a posterior side. Whatever big circle you see in front of vertebra is what? Aorta. Which aorta? Descending aorta. So now what is this? This is, so I will just mark it over here. So when you see this round section over here in front of the vertebra, so what we say, it is the descending aorta. So this is a rule over here, that in front of vertebra, descending aorta. And now what about this another big circle? Now this another big circle is what? It is the ascending aorta. So these two structures are very, very important to identify. And now next we say that there is some irregular structure between these two big circles. And whenever we are talking about this irregular structure over here, what do we say? This is pulmonary trunk. So whatever this irregular structure, this is actually the section of the vessel over here, which is seen like this big section, pulmonary trunk. Now apart from this, what other structures you should be able to identify? See, don't be confused that if you are seeing the inferior view or the superior view, whenever you are taking the sections, it is always the inferior view. Now, what you focus on over here is to identify the structure. You see what is anterior and the posterior side. Once you identify vertebra, in front of it descending aorta, further over here ascending. When you see the descending aorta, what do you see? Just adjacent to it over here, this is the location of the esophagus, because this is a cadaveric section. So that is why it has collapsed over here, and this we say is esophagus. Okay, this is the esophagus. Now adjacent to ascending aorta, there is a structure over here, which is what? It is superior vena cava. So all these structures which I have marked over here, you should be able to identify. Okay, you should be able to identify all these structures. So therefore what we say, answer over here is what? Yes, the answer over here is the pulmonary trunk. Yes, very correct, pulmonary trunk. Now let us see the next question over here. Now this is a question on conjoint tendon. And what does it say? For the conjoint tendon, all are true. Now it is asking all are true except. Okay, so you have to see except. So now let us see conjoint tendon. Now whenever you are talking about the conjoint tendon, we very well know it is formed by aponeurosis of two muscles, which is internal oblique and transverse abdominis, and it is present where? It is present in the inguinal region, right? So we have understood that over here the option A is correct. Okay, we have understood it is option A which is correct. Now let us discuss over here. You try to answer this question. Till then, let us discuss this point over here. Whenever we are talking about conjoint tendon, it is present in the inguinal region. In the inguinal region, you can see this is a location of superficial ring. This is the location of deep ring, and between this we are having the inguinal canal. Now when you are talking about this conjoint tendon, what actually happens? This is the fibers of internal oblique and transversus abdominis, which actually arch over inguinal canal. Okay, which actually arch over the inguinal canal, and then they come medially over here and they form a common tendon, which is given the term as conjoint tendon. As the word suggests, conjoint. Conjoint means common tendon of what? Of internal oblique and transversus abdominis. So what do you see? The fibers are arching over like this, arching over the inguinal canal, and then they are going on the medial most side and they form a common tendon, conjoint tendon. So what we say is this is a conjoint tendon. Next thing, when we say it contributes to which boundary of the inguinal canal. So for the inguinal canal, when you are talking about the inguinal canal, we say anterior wall mainly formed by external oblique, posterior wall mainly formed by fascia transversalis, roof is mainly formed by internal oblique and transversus abdominis. And when you are talking about the floor, in the floor we say it is mainly formed by inguinal ligament and its component lacunar ligament. Okay, these are the main structures. Now over here we are concerned about the conjoint tendon, and for the conjoint tendon we say that it contributes also in posterior wall. Okay, it is contributing in the posterior wall also. So what do you see for the conjoint tendon? It is first of all contributing into the roof and having a small contribution in the posterior wall also. So in the posterior wall, it is having a small contribution, that too on its medial side. Okay, slightly on the medial side. So what we are looking at over here, the conjoint tendon is contributing in the roof also, and it is having a small contribution in the posterior wall also. Fine. Another thing is that when you are talking about the conjoint tendon, this location over here, what is this? It is actually present near this superficial inguinal ring. Okay, this is a superficial inguinal ring, and it is present where? It is present towards its posterior side. So when it is present over here towards its posterior side, it strengthens or it guards this superficial inguinal ring, and it is acting as a mechanism to prevent the hernias. So let us see over here what is mentioned in the points, and I can see that a lot of you have answered the question very correctly. Very correct. First of all, A is correct. B, superficial ring is guarded posteriorly by conjoint tendon. Yes, very correct. As I said, posteriorly it is guarded. Then another point is its weakening in the old age predisposes it to direct inguinal hernia. Yes, this is a clinical aspect associated with the conjoint tendon, that if it is weakened, like in the old age, it is, we say it predisposes to which hernia? To direct inguinal hernia. So this is also correct. And for the direct inguinal hernia, we know it is a hernia which is within the Hasselbeck's triangle. It is within the Hasselbeck's triangle, or you say medial to the infraepigastric vessels. So that one. Now, the last point is contributes only in the roof. No, not only in the roof also, and plus posterior wall also. So that is why this point is not completely correct. It is contributing in the roof also and the posterior wall also. So therefore the answer of this question is D. Okay, direct or indirect inguinal hernia. We say direct is the one which is, the hernia is through the abdominal muscles because they become weak. And when you say indirect inguinal hernia, it is passing through this inguinal canal area due to the persistence of the processus vaginalis. Okay, so that is the main difference in the cause. And for you should be knowing the relation with the infraepigastric vessels. If the hernia is medial to it, then we say direct inguinal hernia. If the inguinal hernia is lateral to infraepigastric vessels, then it is what? It is indirect inguinal hernia. That you should be knowing clinically, because usually they ask you this clinical question. Now in this image, you have to identify what? You have to identify the abducens nerve. Now when we are seeing this question, the PDF will be uploaded over here. So don't worry, the PDF will be uploaded. After the session is completed, it will be uploaded over here. Now this is what this is, the anterior view of brainstem. Right, it is the anterior view of the brainstem. Yes, very correct. Pontomedullary junction, very correct. Dr. Sachin, you have correctly, got the, if you are answering this question and by chance you are not able to answer any nerves, see, pontomedullary junction. Pontomedullary means the junction between the pons and medulla. You are having 3 nerves, 6, 7, 8, and only one nerve is labeled over here, B. So when you see this image, this is the expanded area of the brainstem, pons. This above is midbrain, and below it is the medulla. So a very quick way to answer this question is pontomedullary junction. This is the one which you have 6, 7, 8. Okay, and when you see the 6th one is mentioned over here, so of course the answer will be B over here. But let us see what can be the most correct answer. So you should be knowing specifically. So in the anterior view of the brainstem, when you see this nerve is third one, oculomotor nerve, and then we are having one more nerve which comes from the posterior aspect of midbrain, and that is what? That is the 4th cranial nerve, trochlear. So that is why you say the trochlear nerve comes, only the trochlear nerve arises from the dorsal aspect of the brainstem. Then after that, pons. So for the midbrain we say 3rd and 4th cranial nerve. For the pons we say 5, 6, 7, 8. In which 6, 7, 8 specifically in the pontomedullary junction. It is at the pontomedullary junction. And lastly, when you are talking about medulla, the last 4 cranial nerves are arising from here. So this is the nerves attachment. So that means in the pons, you are having 5, 6, 7, 8. So next number is this one, 5. So we have already numbered 3 and 4. This is 5. And now at the pontomedullary junction, it is 6, 7 and 8. Okay, 6, 7, 8. These 3 nerves. Now as we come towards the medulla, what we see, the last 4 nerves. So for the last 4 nerves, what do we say is, this one is 9, below it 10, below it 11. Okay, they are arranged from above to below, 9, 10, 11. Now what about the 12th? This is whatever nerve rootlets have been shown over here at this location. This is the location for 12th. This is the location for the 12th. And what is it? Over here, if you see, this is the pyramids, and more lateral to it, you are having the olive. So what we say is, between the olive and pyramid, you are having the 12th cranial nerve. And if you go behind the olive, you are having 9, 10, 11. Okay, this is the understanding over here, that how the nerves are present in the anterior view of the brainstem. And now when you are memorizing it, easy way to memorize it is what? You are always going from the center towards the outer side. ठीक है, center से आप बाहर की तरफ जा रहे हो. How? First of all, you are going like this, and again you are going like this. So this is an easy way to memorize over here in the nerves over here in the brainstem. You are always going from inner to the outer side, from the center to the outer side. So first of all, over here, center to the outer side, first nerve 3, 4, 5. Okay, again you are going from center to the outer side. So you say 6, 7, 8, and after that 9, 10, 11. And the 12th one, which is the last one, we say odd one out. It is totally present in the separate location, at this location between olive and pyramid. So this is an easier way to memorize the cranial nerves location or attachment to the brainstem. And now we perfectly know that the answer of this question is what? Yes, the answer of this question is this one, arrow marked structure B. This is the abducen nerve. Yes, very correct. I can see a lot of you have tried to answer it. And please, please, please don't focus on the pain, on the stress, on the anxiety. Don't focus on this. Focus on your progress. Each and every person will be having all kind of feelings, like anxiety will be there, doubts will be there. You will be feeling that it is such a tough time. ऐसा लग रहा होगा कि अरे भाई इतना tough, इतनी मुश्किल आ रही है, समझ नहीं आ रहा लाइफ में क्या होगा, आगे क्या होगा. बहुत सारे thoughts दिमाग में होंगे. But rather than focusing on that, focus on your progress, that you progress each and every day. Each and every day you are getting a new chance to strengthen yourself, to improve yourself. So utilize each day to improve yourself. So your focus should be on your progress rather than on all the distractions, rather than all this anxieties. Don't focus on that, but focus on your progress. So now let us see this question. This is a slightly different question which I have given over here. Yes, yes, Dr. Pramendra, very good. Cranial nerves, you have said very correct. The mnemonic. And Krishna, yes, hello to you. Okay, so now let us try to answer this question. See, when you see this question, let us try to read this question. A 68-year-old woman presents. So now, first of all, when you are seeing this long question, now, let us see what is the last line. The last line says, which artery is blocked? And when you see the options over here, by seeing the options, you know, we are going to talk about the syndromes. Either it is the medullary syndromes, Brown Sequard, or Weber's. And when you are talking about the artery occlusions, then you know it is either medial medullary or lateral medullary. So you have to decide between what? Pica and anterior spinal. Okay, so you already know by seeing this question that either of two will be the answer. And now let us read the question. Yes, very correct. I can see a lot of you answering very correct. So now when you see this question, now when you see the symptoms over here, dizziness, nystagmus, so dizziness, nystagmus, ataxia, and along with that, loss of pain and temperature. Now when you see ataxia is on the right side, all the symptoms are on ipsilateral side. In the lateral medullary syndrome, only one symptom is contralateral, which is contralateral loss of pain and temperature. Okay, so I will show you the symptoms over here for the lateral medullary or the Wallenberg syndrome. All the multiple symptoms, the ataxia is also there. and everything is ipsilateral. Only one symptom is contralateral, which is contralateral loss of pain and temperature of body. So whenever you see multiple symptoms along with this specific symptom, you say it is Wallenberg, which is the occlusion of pica. And whenever you are answering this question, if by chance the vertebral artery is also mentioned, so vertebral artery is always given more preference than pica, right? Now, by reading this question, you are clear that it is pica, and if this image is also given, so how to decide over here with the help of image? Now, this is transverse section of medulla. Okay, this is the transverse section of medulla, and whenever you are seeing the transverse section of medulla, we very well know that towards the anterior side, this is pyramid, and as you go laterally, this is the location of olive, and deep to the olive you can see this inferior olivary nucleus is present, right? And now when you see this reddish colored area, this is of course on the lateral aspect of medulla, and when the ischemia is on the lateral aspect of medulla, of course it will lead to what? Lateral medullary syndrome. So this ischemia is due to what? Pica, that is posterior inferior cerebellar artery. Right, so this is the answer over here, and I can see that a lot of you have correctly answered this question. Yes. Now, because we are mentioning this, we should also be knowing that when we see this arterial image, what is the location of this pica? So when you are seeing this arterial image, over here, this is the vertebral artery, and on the lateral aspect of vertebral artery, this branch is pica. And if you see a branch on its medial side, this is a location of anterior spinal artery. This is also, they can ask you the question on the basis of the arteries also. So you should be able to identify these two arteries. So we have understood Wallenberg. Now, over here only we will mention the medial medullary also. And for that also I have given the transverse section of medulla. Same section. It is the same section, but when you see over here, now the reddish colored area has shifted to inner side, medial side, and if it is a medial side, so medial medullary syndrome, and due to what? Anterior spinal artery occlusion. So what is the symptom over here? We say the specific symptom over here is cranial nerve 12 involvement. This is a very specific symptom over here, and it is ipsilateral. The other symptoms are contralateral. So a very specific symptom over here is cranial nerve 12 involvement, along with the other symptoms, contralateral hemiplegia, contralateral loss of the conscious proprioception, which is due to the dorsal column. Now let us compare it with the Brown-Sequard syndrome. So over here, see, you can see with the symptoms, we are also discussing the image also. Okay, this image for medial medullary, this image for Brown-Sequard syndrome. What is that? Hemisection of spinal cord. Half of the spinal cord is gone, and then wherever the hemisection is there, below that level you are having the symptoms. What is the symptom? You are having ipsilateral hemiplegia, ipsilateral loss of conscious proprioception, and along with that contralateral loss of pain and temperature. These three combination of symptom is there in the Brown-Sequard. If we compare it with the Weber's, this is the image for the Weber's, and in this it is at the level of midbrain. So this is the transverse section of midbrain over here, and in the transverse section of the midbrain, if they show you this affected area over here, this is the affected area over here, and this is for the Weber's syndrome. What is this? A specific point over here is a cranial nerve 3 involvement, which is ipsilateral side along with contralateral hemiplegia. Okay, so this is the image for the Weber's syndrome. So now we know the answer is what? It is pica, posterior inferior cerebellar artery. Okay, now let us move on to the next question. Now in this question, a patient presents with complaints of drooping of the upper eyelid, which we know it is what? It is ptosis. The patient is unable to see in upward direction. Eyeball is in downward and outward position. See, whenever we are answering, yes, very correct. Whenever we are answering this question, when you see the options, you are aware of this, that it is something related to eyes, because the nerves are what? 3, 4, 6 and optic nerve. So it is something related to eye. And now when you see this point, this is a very specific point. This is a key word. the eyeball is in which position? Down and out position. And when you see this keyword, so I will let you answer the question. Till then we discuss. On examination, there is fixed dilated pupil. Fixed dilated pupil, fixed means it is non-reactive to light. Okay, so that is why we have written over here the loss of light reflex is there. It is not reacting to the light. So fixed pupil, fixed and dilated pupil. So now whenever you are seeing the symptom, yes, very correct, very, very correct. It is the oculomotor nerve lesion. So this keyword which we mentioned over here, the down and out position of the eyeball, it is a keyword for what? For the oculomotor nerve lesion. Whenever you see this symptom, you quickly say it is oculomotor nerve lesion. And another point which is very, very important in this is fixed and dilated pupil. So these are the 2 points. Why? Because all the muscles are supplied by oculomotor nerve except LR6 and SO4. So LR lateral rectors by 6th cranial nerve, superior oblique by 4th cranial nerve, they are spared, and due to their sparing, they are taking the eyeball into this down and out position. Fine. So therefore the answer of this question is oculomotor. Now if I say what about the other nerves? If the trochlear nerve is gone, so you know superior oblique will be paralyzed. It is a superior oblique which is paralyzed. And in this we have a very specific symptom, difficulty in looking downwards. Okay, this is a specific symptom which will be mentioned in the question. Like they will be mentioning that the patient is having difficulty in reading the newspaper, or he is having difficulty in going down the stairs. So looking down, he is having difficulty in looking downwards. This is a keyword for trochlear. Now what is the keyword for other one? When you say abducent, it is of course lateral rectus which is gone, and it leads to convergent, or we say medial squint. If the lateral rectus is paralyzed, so the eyeballs are pulled by medial rectus towards the medial side, and therefore what happens, the eyeball when it goes medially, we say convergent or the medial squint. So this is a specific symptom which occurs in the abducent. And when you say optic nerve, the optic nerve you very well know the visual pathway, the different lesions can be there, and when the optic nerve, if one side optic nerve is gone, the complete blindness on that side will be there. Okay, so this is, now we know the answer over here is oculomotor nerve. Now let us quickly come to next question. Very correct. Now quickly come to the next question. Let us read the question over here. The venous cut down is being done for the excess of great saphenous vein. Now when you see this word, you know that something related to lower limb, something related to great saphenous vein. After this procedure, the patient complains of what? Loss of sensation where? Medial side of leg, medial side of the foot. So everything is what? Now the thing is that everything is medial. Everything is medial. The sensory loss medial, and when I say great saphenous vein, it is also present on the medial side. And a very important point over here. So try to answer this question. Which nerve can be gone over here? I'm waiting for that. Which nerve can be gone over here? Okay, so great saphenous vein, it is having a very, very important relation. It is related to a nerve which is saphenous nerve. It is a very, very important point. It is related to what? Saphenous nerve. And now when we say great saphenous vein, this is the image which is showing this complete great saphenous vein. It is running like this throughout the lower limb, and it is a great saphenous vein present on medial side. Yes, very correct. I can see you are confused between B, C and D also. Okay, so let us see the explanation. The great saphenous vein, it is completely present over here on the medial side, and as I said, it is related to, there is a nerve which is running along with that. What is this nerve? Saphenous nerve. Okay, we just mentioned saphenous nerve. Again, on which side? Medial side. Of course, medial side. Great saphenous vein भी medial पे है, तो saphenous nerve भी medial पे होगी, है ना? So it is also on the medial side. So therefore, whenever this nerve is gone, the symptom will be where? On the medial side. So sensory loss is completely on the medial side of the leg as well as going till the medial side of the foot. Why? Because if you see the distribution of the saphenous nerve, this is towards the medial side of leg, and we say medial border of the foot. Now, this is the sensory nerve. When we are talking about this, we say it is a sensory branch or nerve. It is actually a branch of what? It is a branch of the femoral nerve. It is a branch of the femoral nerve. So it is a branch of femoral nerve which is completely sensory, and therefore it is supplying the skin over here. So when this nerve is gone, it leads to what? It leads to the sensory loss in this specific area. And when you are talking about the foot, you very well know in this foot, first web space by deep peroneal, the rest of the dorsum of foot by superficial peroneal, which is also going to the lateral aspect of the foot. And now we have also mentioned the saphenous nerve. So now we know what is the answer of this question. Now I hope that you will be able to understand over here that why the answer is saphenous. Okay, so the answer is saphenous. Why it is not obturator? Obturator because the sensory loss is in the leg area and foot area. They are not saying thigh. The obturator nerve is for thigh region. You can say medial side, but what? Thigh region. It is not in the leg area, it is not in the foot area. So because it is leg and the foot, so that is why the lower side nerves. And we are having the answer is saphenous nerve. Yes, very correct. So now we know the answer over here, saphenous nerve. Now let us go to the next question. Now when you see this question, this is a very, very, very important question, high yield question, and anything can be asked from this topic. And you know very well what is I'm going to discuss is, we are going to discuss this facial palsy questions. Okay, the facial injury or the facial lesions. So it is a question on the facial nerve. Any type of question can come on the facial nerve. This is at present the very, very high yield topic. And okay, now let us first of all read the question. See, whenever you are doing this question, when you read the options, you quickly know that it is related to facial nerve. You have to decide what? First of all, you have to decide LMN, UMN, and then you have to decide the site. Whenever you are doing this type of question, thank you dear Dr. Bubbles. So whenever you are doing this type of question, what is the keyword? There can be a lot of points which can be given in this question, but the keyword will always be transverse wrinkles on forehead. First of all, look what is happening to the transverse wrinkles. It is written over here, loss of transverse wrinkles. When you say loss of transverse wrinkles, by that you quickly say it is LMN, low motor neuron lesion, because only in the low motor neuron the transverse wrinkles, or we say the upper half, is affected. But when you say UMN, upper motor neuron lesion, the forehead is spared. So when you see the symptom, quickly you say LMN, and whenever you are saying LMN, you already know it is on ipsilateral side, right? Ipsilateral side. And when you see the side which is mentioned over here, right side, means the LMN will be on which side? Ipsilateral means same side, right side. So with this point only, we can quickly decide this this diagnosis. When you say transverse wrinkles, LMN, which side? Right side. So ipsilateral symptom, so that is why right side LMN is there. So when you see the options over here, what you say? First of all, you say LMN, LMN. Okay, you have quickly ruled out UMN, and now in that you say what is the answer? Yes, it is the LMN lesion of the right facial nerve. Very, very correct. I can see a lot of you have answered this as B. And now we have understood that how to approach this question. What are the rest of the symptoms? Inability to close the eyes. Yes, it is on the also on the right side. And the deviation of angle of mouth. Now, whenever you are talking about this deviation of angle of mouth, for this we say it is towards normal side. Because the normal muscles, they pull up the face towards itself. So the deviation of the mouth is towards the normal side, and that is why it is written over here left side. Okay, the deviation of the face is towards the left side. But when you say angle of mouth, for the angle of mouth, we have one more point. So we will quickly discuss over here. Very, very important. In the UMN, it is what? Supranuclear lesion, means the lesion can be in the cerebrum or the fibers which are coming from the cerebrum. And we know it is affecting what? Contralateral lower half, and the forehead is spared. But when you say LMN lesion, either it is the nucleus involved or infranuclear. Infranuclear means the facial nerve is affected. And in that we say ipsilateral, whole half of the face is paralyzed, including the forehead. When you say symptoms, all these symptoms are present, in which you know very important is transverse wrinkles. Another very important symptom is when you say angle of mouth. When you're talking about angle of mouth, it is tilted down on side of lesion, same side of lesion. Okay, so there are 2 points over here which you should be very well knowing over here. When you're talking about the side of the lesion, when you see this is the side of the lesion over here, the angle of the mouth is tilted down on the side of the lesion, on the same side of lesion. Another thing is that we also have one more point for angle of mouth. The angle of mouth is pulled towards normal side. So if this is the Bell's palsy side, angle of mouth going down, tilted down on the Bell's palsy side means the same side of lesion. When you say normal side, the angle of mouth is pulled, or we say angle of mouth is deviated towards the normal side and it is slightly pulled up. So these are 2 points for the angle of mouth, which are both statements are correct. One statement we mentioned over here, another statement we mentioned over here, deviation of angle of mouth towards the normal side. So you should be able to differentiate this point, and the answer is this one. Now because we are discussing the facial nerve, I will give you more questions which are related to facial nerve, because you should be able to answer all the questions related to facial nerve. So this is the extra question I am giving for the facial nerve. In a patient with facial nerve injury, paralysis of all facial muscles on one side. Now when you see this word, what you understand is it is element. All the facial muscles on one side of the face are affected. Okay, still if we say that we are not much clear, so let us see further points. With hyperacusis, loss of taste sensation in anterior 2/3 of tongue, and the loss of lacrimatial also found. What is site of lesion? This is another type of question which can come on facial nerve. They can ask you, what is site of lesion? कौन से point पे इंजरी हो रही है, ये आपको आंसर करना है. Now what you see is over here, the options are cortical lesion, lesion in the internal capsule, stylomastoid foramen, geniculate ganglia. Yes, very correct, very correct. All of you are answering is very correct. D, yes, lesion at geniculate ganglia. So for this, what you should be knowing is that this schematic image should be clear to you. First of all, we will discuss the course of the facial nerve. Facial nerve starts from the facial nucleus, then it passes through a foramen internal equistic meatus, and when it is passing through it, we say from the internal equistic meatus till the next foramen, stylomastoid foramen, it is passing through ear. So in this portion it is passing through ear. It comes out of the ear by stylomastoid foramen, and then the facial nerve reaches where it is going towards the face. Okay, it reaches towards the face. So this is the whole pathway of the nerve, and between these two foramens it is present in the ear, where it is giving these 3 branches. What is the order of branches? First, greater petrosus, second, nerve to stapedius, third, chorda tympani nerve. Now, whenever we are talking about the lesion, if the lesion is at the level of stylomastoid foramen, so if the lesion is at this level, element lesion of facial nerve will be there, and we say it leads to typical symptoms of Bell's palsy. Right? If I say the lesion level goes more proximal, if the lesion level is over here, so now if the lesion level is over here, which is proximal to chorda tympani branch, so along with the Bell's palsy symptom, you will have additional symptom which is due to the involvement of chorda tympani nerve, so loss of taste sensation on anterior 2/3 of tongue. Now if I take the lesion more proximal, if I say more proximal over here, so one more symptom is added due to the involvement of nerve to stapedius, and it leads to hyperacusis. If I take the lesion more proximal, means at this level where the greater petrosal nerve is arising, so now you have an additional symptom, loss of lacrimation. So what is happening? We are talking about the lesions at different levels. अगर एकदम initial point पे है, तो सिंपल बेल्स पैल्सी सिम्टम, जैसे जैसे लीजन प्रॉक्सिमल गया तो एक एक सिम्टम उसमें ऐड होता जा रहा है, ठीक है, सिम्टम्स उसमें ऐड होते जा रहे हैं, कैसे, किसके अकॉर्डिंगली, कौन कौन सी नर्व्स उसमें अफेक्ट होती जा रही है, तो जो जो नर्व्स उसमें इंक्लूड होती जा रही है, जो जो नर्व्स उसमें अफेक्ट होती जा रही है, उसके अकॉर्डिंगली सिम्टम्स एड अप होते जा रहे हैं. नाउ ओवर हियर इफ आई टॉक अबाउट द ग्रेटर पेट्रोसल नर्व, इट इज एक्चुअली अराइजिंग और इट इज लोकेटेड एट व्हाट लेवल? At this level you are having geniculate ganglia. At this location the greater petrosal nerve is affected, located, and if the geniculate ganglia is gone or if the lesion is at the geniculate ganglia, then all the symptoms will be observed, all these three symptoms plus the Bell's palsy symptom also, like all the symptoms of Bell's palsy. So therefore the answer of this question will be what? Lesion at geniculate ganglia, because it is having this Bell's palsy symptom plus it is having all the three symptoms. If the lesion is at only stylomastoid foramen, so only the symptoms of Bell's palsy, that facial symptoms are only seen. And if I say cortical lesion or internal capsule, it is going to lead to upper motor neuron lesion. Yes. Now, this is to find the site or the location of the facial nerve injury. One more type of question for the facial nerve. So this is one more extra question I am discussing. Try to answer it. Okay, now one more question is there. A female underwent parotidectomy. We know that whenever you are doing the parotid gland surgery, over there when they say drooping of angle of mouth or the angle of mouth is tilted down, you very well know that the facial nerve palsy is there or the facial nerve injury is there. And over here when the drooping of angle of mouth is there, we know the facial nerve is affected. Now they are saying which branch of facial nerve is responsible for that. So this is another type of question. Yes, you are very right. In the geniculate ganglia, there can be that virus also. So yes, very correct. The answer of this question is what? It is marginal mandibular nerve. Which branch of facial nerve? How we decide over here when we are talking about the terminal branches of the facial nerve. When the facial nerve, it reaches the face, it terminates like this. Okay, terminates like this. You know the branching pattern of the facial nerve, it is given the term as pes inserinus because it resembles the feet of the bird. So pes inserinus. Now when you are saying the branches are like this. Okay, you keep your hand in this way. The branches are like this. Now one branch is going where? Temporal area. So that is the temporal branch. If it is going to temporal area, temporal branch. Another branch is going to zygomatic area. This is zygomatic branch. Third branch is going to buccal area, buccal branch. Fourth branch, if you see, is along the lower border of mandible, marginal mandibular branch. And the fifth branch is going towards the neck area. So what is that? This is the cervical branch. So how it is labeled over here? First branch is this one, temporal area, temporal branch. Second is going over here, zygomatic branch. So this one is temporal, this one is zygomatic. Then over here, this is going to the oral cavity area, buccal branch. This one is running along the lower border of mandible, marginal mandibular branch. And the one which is going towards the neck, it is the cervical branch. Now, according to the area where it is going, it will supply the muscles of the face over there. Okay, if I say that you are not able to memorize the muscles over here, but you can see the direction of the nerves. Now, if I say the symptom occurs in the angle of mouth, so that means towards the angle of mouth, the lower branches can be there. And when you say marginal, because the drooping of the angle of mouth is there, so the drooping of angle of mouth is related to the muscles on the lower side, the depressor muscles, the depressor labia inferioris and depressor angularis, which are towards the lower side, and they are responsible for the movements of lower lip, the lower lip movement or angle of mouth. And towards this area, the lower side area is mainly supplied by what? Marginal mandibular branch. So for the drooping towards the lower side of face, below the lower lip, the muscles which are present, they are supplied by this, and the cervical branch supplies the platysma. So therefore we say, when you are talking about the effect on the lower lip or drooping of the angle of mouth, it is due to the marginal mandibular branch. If by chance it is not given, then you can also go for cervical branch because it is supplying the platysma, and the platysma also contributes in the in this movement of angle of mouth, in this lower movement of angle of mouth. So in fact we say this middle, in fact we say the marginal mandibular branch, answer is more better than cervical. If it is not given, then you can go for cervical branch. So these are all the questions which are related to facial nerve, and each and every aspect of the facial nerve question you should be able to deal with. Very, very important. So tell yourself you can and you will. Always keep telling yourself that yes, I can do it. Each day is an opportunity to gain more information, to gain more knowledge, to revise the previous knowledge, and to improve yourself. So tell yourself you can, and of course you will be able to do it. And now a very, very important question, which is, a very frequently asked question, and let us try to answer this. Now, if you see this image over here, what is this? This is the image for the horizontal planes in the abdomen. And when you are talking about the horizontal planes, we are having the subcostal plane, transtubercular, then also we have transpyloric, and one more supracrustal. So there are 4 planes which you should be able to tell. Now, when you see this plane, identify the plane and tell vertebral level. Tell the vertebral level. Yes, Dr. Sachin, we can and we will. Very correct. Very correct. Okay, you think about the answer. Till then, we will discuss that what are the planes over here. Whenever you are talking about the abdominal quadrants, in the abdominal quadrants, you are having 2 horizontal planes in which the upper one is subcostal, lower one is transtubercular. Right? The subcostal at L3 level, transtubercular at L5 level. So when you are talking about these 2 planes over here, this is L3 and this is L5, and both of them are what? Both of them are upper border of the vertebrae. This is also upper border and this is also upper border of L5 of the vertebra. Now when you are seeing these 2 planes, they are present either above the umbilicus or just below the umbilicus. This is a way to identify over here. The planes are either above the umbilicus or below the umbilicus. This is the plane for the quadrants, right? Another 2 planes are what? Another 2 planes are transpyloric and supracrustal. When you say transpyloric plane, it is higher up. It is a higher up plane at the L1 level, lower border. When you say supracrustal plane, this is a plane which is passing through the highest point of iliac crest, and it is at the level of what? L4, lower border. So these are the 2 other planes. Now when I say transpyloric, higher up means that it is away from umbilicus. So if I say that this image is there, if there is a plane which is shown over here, this will be transpyloric. Of course, it is above the subcostal because it is at the level of L1. So it will be above it. And what you see, it is distant or it is away from umbilicus. A lot of distance is there between the umbilicus and this plane. So if you see a plane just above the umbilicus, you know it is subcostal. But if you see a far away plane from the umbilicus, you know that is the L1 level, and that plane is what? Transpyloric. So when you see this image, now when you see this image, what do you see over here? When you see the abdomen, this is a location of umbilicus. If I say one plane over here, another plane over here, so this we know is subcostal, below it is transtubercular. Okay, below it is transtubercular. But now what we see, the another plane has been put over here, which is very higher up plane. It is very away from the umbilicus, and this is actually what? It is the transpyloric plane. So now you know that how to approach this question. If the image is given like this, then also you can answer. If the image is given like this, then also you can answer. And and if this image is given in this way, then also you know that how to approach to this question. So now what is the answer of this question? The answer of this question is transpyloric. Only one option having this transpyloric, and you know it is L1 level, what? Border, lower border. So the answer of this question is transpyloric plane. Yes, very correct, Dr. Sachin. So a third, very correct. L4, highest point of iliac crest. Krishna, very correct. Supracrustal. Yes, yes. Okay, now coming to the next question, it is a very important question for you. And when you see this image, you should be able to tell that what is this sign tested. This is a Trendelenburg sign which has been tested. And now the thing is that when you see this question, every one of us know that it is something, a nerve injury, some gluteal nerve injury is there. The point is that you should be able to decide between superior, inferior. Then you should be able to tell the side also. That is also very important. So when you say this test, Trendelenburg sign is there, the patient is having lurching on one side, and when on examination it was found that when he keeps his right foot on the ground, the pelvis drops to left side. The sign shown in the image is positive, so you know that what sign is this. What is the most likely diagnosis? Very, very correct. I can see a lot of you are answering A. Yes. So now when you are talking about this sign positive and the symptoms, you know it is superior gluteal nerve, and either this one or this one, so you quickly rule out the C and D, because the inferior gluteal nerve supplies gluteus maximus and superior supplies the medius and minimus. Now you have to decide between the side, and we say the answer over here is right superior gluteal nerve injury. The answer of this question is A. Yes. Why? Because the pelvis drops to opposite side. So whenever you are talking about the superior gluteal nerve injury, medius minimus paralyzed, pelvis falls to which side? Opposite side. Opposite side means it is falling towards the normal side. You can say this Trendelenburg sign is positive and lurching gait is present. Okay, so what is happening when you keep the right foot on the ground? So if I say this foot is on the ground, the pelvis is dropping on the opposite side. And a very easy way to answer it is that you just see which foot is on the ground. This is just a trick to answer the question. Which foot is on the ground? That side nerve is gone. Okay, this is just a trick to answer it. So when you see right foot is on the ground, it is a right superior gluteal nerve injury. And even if they ask you about the muscles, so the answer will be paralysis of which muscle? It is a paralysis of right gluteus medius and gluteus minimus. Okay, again it is the right gluteus medius and minimus. Yes, very correct. Very correct. So now we know the answer of this question is A. Let us quickly go to the next question. Now, this is an easy question, but answer carefully, because what is there? We are testing 2-3 points together. So you have to answer carefully. Whenever you see this X-ray, whenever you see this point, it must be an easier question for you. But whenever you are answering, you can say A is this, B is this, C is this. So you should be correctly answering the question. First of all, correctly identify the joint. Then correctly see that which is the correct combination. Choose the correct combination. This is very important. So now let us see what is this. This is the X-ray of the hand, and a lot of joints are present over here. First of all, let us try to identify the joints over here. Now when you see this image, what do you see? A. A is what? Now when you see this bone over here, we know it is metacarpal. Okay, this is the metacarpal. And what is this? This is the phalanx. This is the phalanx. Over here also, this is phalanx, this is phalanx, this is phalanx, and this is metacarpal. Right? Over here, this is the carpal bones. This bone is what? This is the radius, and this is the ulna. So we have identified all the bones over here. Now, next is, what is the joint? First of all, this joint. Now, this is a joint which is between the first metacarpal. This is the first metacarpal. Why? Because this is the thumb side. You can see on the thumb side, you are having only 2 phalanges. So we identify this is the thumb side, and as well as you can identify in the image very well that this is the thumb side. So this is a lateral medial, and the counting always starts from the thumb side. So what we say is A is first metacarpal joint. Okay, this is the first carpo-metacarpal joint. Now let us see B. B is what? Radius, and these are the carpal bones. Okay, this is the scaphoid and the lunate over here. So now the joint, the arrow is at this joint cavity. And what is this? This is a wrist joint. This is a wrist joint. So B is what? B is wrist joint. When you say C, let us see what is C. See the arrow. You have to see carefully where the arrow is there. Arrow is not towards this joint cavity. It is slightly over here, which is between radius and ulna. So between the radius and ulna, this is the radio-ulnar joint. Which one? It is on lower side. So inferior radio-ulnar joint. So when you are talking about C, C is inferior radio-ulnar joint. Okay, so we have identified the joints over here, and another joints. So let us first of all see what is, okay, before we further talk, we say what is this joint? This is the metacarpophalangeal joint. When we are talking about the joints between the phalanges, this one, this one, this one, this one, so we say this is distal interphalangeal and this is PIP, which is proximal interphalangeal. So you should be able to identify all the joints in this image. And now when we say what is the type, this is a saddle variety synovial, this is ellipsoid variety of synovial, and now when you say radio-ulnar, superior and the inferior radio-ulnar both are pivot variety of synovial. So now you know what is this A, B, C. A is saddle, B is ellipsoid, and C is pivot. So let us see what will be the correct answer over here. Yes, now the correct answer over here is D. Yes, syndesmosis, of course, yes, it is in the middle radio-ulnar joint. Very correct. Yeah, so the answer over here is what? The answer over here is D. Saddle, this is a saddle, this is ellipsoid, and this is the pivot variety. Now let us come to the next question. Which artery pulsation is done over here, and now what is the location? Yes, mnemonic thumb, yes, saddle. Okay, now when we are answering this question over here, so if you have any kind of confusion over here, how to answer this question? First of all, when you see this image, where the pulsation is being done, the pulsation is done over here. What side? It is the dorsum of the foot. Okay, because this is the dorsum of the foot, so the artery name will be what? Dorsalis, dorsum of foot. Foot means pedis. Okay, either it can be this one or this one. So the artery on the superior aspect or the dorsum of the foot is named accordingly dorsalis pedis. So first of all, by seeing this image, you have quickly ruled out A and B. Now you say what you have to basically decide between C and D. Now what we say is that whenever you are doing this pulsation, of course when you see the pulsation done, it is near the great toe, and the tendon which is going to the great toe is what? Extensor hallucis longus. So the pulsation is always along or near the extensor hallucis longus tendon, which is going to the great toe. But now if you see how I have drawn over here, this is how the artery and the tendon is present. And now when you see what is the location of dorsalis pedis artery, yes, it is lateral to extensor hallucis longus. So always remember this image, and just keep in mind that dorsalis pedis artery, what is the location? Lateral to the tendon of extensor hallucis longus. So the answer of this question is D. I could see that a lot of you were confused between C and D. So today only, please remember over here, it is lateral to this tendon. And because we know that the pulsation is a very, very important question, so let us see at the pulsations. This pulsation is a radial artery pulsation, and for the radial artery pulsation, when we talk about this, we say it is lateral to what? Tendon of flexor carpi radialis. Okay, this is a specific location for pulsation, lateral to the tendon of flexor carpi radialis. Another pulsation is brachial artery pulsation, which is done over here. You can see in this image, the pulsation has been shown, done at the cubital fossa. And when the pulsation is done at the cubital fossa, so you can see this artery is shown. And when we are talking about this artery, it is related to biceps tendon. And where it is present medial to biceps tendon. So the pulsation of the brachial artery is medial to biceps tendon. Another pulsation We have already discussed this one. Posterior tibial artery pulsation, you can see it is on the medial side, and when we are talking about this, we say it is between what? Medial malleolus and tendocalcaneus. And which border of tendocalcaneus? Yes, medial border of tendocalcaneus. Another pulsation you can see over here, this is in the neck area over here, common carotid artery pulsation, which is at what point? Carotid tubercle or Kazanec tubercle, which is what? A component of C6 vertebra. So this is also very, very important that this pulsation is done at carotid tubercle of C6. And in fact, when we are talking about the C6 corresponds to, it corresponds to lower border of cricoid cartilage. This was a recent question which was asked in January. The common carotid artery pulsation is done at the level of which cartilage? So we say C6 level carotid tubercle, which itself is lying at the level of lower border of cricoid cartilage. So that is why in that question the answer was cricoid cartilage. So you should be knowing this. This was a recently asked question. So therefore now we know the answer of this question is D. Now let us quickly go to this question, and it is none of the questions are the complete question bank is incomplete if this pharyngeal arches is not mentioned. So pharyngeal arches, pharyngeal pouch, this is a very, very high yield topic which can be asked anytime. So we can never leave this question. We should be knowing this point. We should be able to revise it. And this is a question which should not go wrong. Please take care that this is a high yield topic, but a scoring topic for you. It should not go wrong. And I want every one of you to answer this question. Okay, you are saying, ma'am, please put separate video on the type of joints. Okay, I will try to do that. And is this session also important? Yes, of course, this session is also important for your NEET PG. You will find it very helpful. So now when you see this image over here, first of all, you should be able to identify that all this is the pharyngeal apparatus. What is this? What is 1? So let us see what is A. Okay, let us see what is A. A is first arch, B is second arch. This is the first and the second pharyngeal arch. Okay, yes. I can see a lot of you are trying to answer it. Yes, D. Very correct, very correct. So this is A is first, B is second arch, and then this is the third, and this is the fourth, and this is the sixth arch. So I will just label over here. This is the third, this is the fourth, and this is the sixth arch. Okay, this is the location of the pharyngeal arches. But when we see the arrow towards the inner side, so arrow towards the inner side, it is on the pouches. When you say first pouch, this is the second pouch, see the arrow is on third pouch. And this is what? This is 4. So what is this? This is the pharyngeal pouches. So this is third pharyngeal pouch. So when you see this brown colored area, this is what? Arches. We have labeled all the arches. On the inner side, you are having the depressions, which are pouches. First, second, C is third pharyngeal pouch, and this is fourth. Similarly, when you say if the arrow is on the outer side, this is what? These are clefts, which are on the outer side. 1, 2, 3, 4. Okay, these are the clefts. Now we know that A is first arch, B is second arch, C is third pharyngeal pouch. A forms, so what we have to tell is which is incorrect statement. Yes, very correct. Which is incorrect statement? A is forming sphenomandibular ligament. Yes, it is correct. It is formed by first arch. B is forming stapes. Second arch is forming stapes. Very correct. C, third pharyngeal pouch is forming thymus. Very correct. And when I say third pharyngeal pouch, it forms what? It forms inferior parathyroid gland, not the superior. It actually forms inferior parathyroid gland. So that is why this statement is not correct. And the answer of this question will be D, as all of you were saying. The answer is D. So we very well know over here, very, very important when you are talking about the first arch, you should be knowing all the derivatives from the first arch, in which predominantly M is there. So all the derivatives from M. Then A, you are having two structures which we remember by A for anteriors, S for sphenoid, T for tensors, I for incus. In this we say the most important derivatives are what we have labeled over here. First is malleus mandible, very important. They were recently asked question. Muscles of mastication, nerve of this arch, mandibular nerve, artery, maxillary artery, and very important sphenomandibular ligament, yet to be asked in your exam. Expected question, and another is incus. What you understand over here is that malleus and incus, they are derived from first arch. So first arch forming two ear ossicles, malleus and incus, and therefore we should remember that when we are talking about stapes, it is derived from second arch. It is derived from second arch, the third ear ossicle. So from the second arch, mainly the stapes, styloid process, artery for this is styloidal artery, and stapedial artery, and the nerve for the second arch is facial nerve. These are the main structures for the second arch. Now when you say pouches, these are the derivatives from the pouches, in which we say very important third pouch giving rise to thymus and inferior parathyroid gland. And another very important is second pouch. The second pouch gives rise to palatine tonsil. So now we have understood that what are the structures derived, and the answer of this question is D. Very correct, all of you. The answer of this question is D. Yes. Now let us go to the next question. Try to answer this question. So the pharyngeal arches question, it is very important. First arch, you have to remember. By that you can also exclude for the other arches. Artery is very important for each of the arches. Then pouches we have just memorized. Third pouch very important, and also the second pouch, palatine tonsil. Now when you see this question, over here, what do you see? A surgeon is performing a surgical procedure where? In the posterior triangle of neck. Okay, in the posterior triangle of the neck. So I can see that yes, you have trying to answer the question. Now when he is operating in the posterior triangle of neck, accidentally a nerve is injured, and due to this nerve injury, the patient is having difficulty in elevation of shoulder on the same side of lesion. And on examination, what is there? Dropped shoulder. It is dropped shoulder. So now when you see over here, difficulty in elevation of shoulder means loss of shrugging, right? And due to this loss of shrugging, the patient is not able to elevate the shoulder. So due to this, the shoulder drops on that side, leading to the dropped shoulder. So now when you see, yes, Pushpa, it is a Pushpa movie, drop shoulder like this. So now when you see this question, now you should be seeing what the question is actually asking, because when you see the question, when we see the spinal accessory nerve, this is the thing which we actually mark quickly. But read the question. What is the question? Which muscle is involved in this case? If you see spinal accessory nerve, this is also correct. Sternocleidomastoid, this is also related to it. Trapezius, this is also related to it. There are three options which are related to this question. So you should be seeing that what the question or what the examiner is asking. If they ask you that what nerve is injured, answer will be spinal accessory nerve. But over here we are asking which muscle is affected in this case. So according to the symptoms, when you see the symptom, the difficulty in elevation of the shoulder, loss of shrugging, and the drop shoulder, both the symptoms are due to paralysis of trapezius. Okay, so the muscle which is paralyzed, according to the symptoms over here, what will be the best answer? Because we have to answer the muscle, the answer will be trapezius. If the question is which nerve is injured, then answer will become spinal accessory. But specifically if you see which muscle is affected. So we have asked about the muscle, we have not asked about the nerve, so the answer will be trapezius. Yeah. Yes, muscle पूछा है तो आंसर हो जाएगा आपका trapezius. When you say sternocleidomastoid, due to this, what happens? Difficulty in, it is the difficulty in turning the head or the neck. Okay, so what is actually happening over here when you see this condition? This is a drop shoulder. We are discussing about the spinal accessory nerve injury, which is supplying two muscles, trapezius and sternocleidomastoid. When the spinal accessory nerve is gone, both the two muscles are affected. What are the specific symptoms by paralysis of trapezius? The specific symptom is loss of shrugging or difficulty in elevation of shoulder plus drop shoulder. What is the specific symptom due to sternocleidomastoid? It is difficulty in turning of the head. So whenever you are turning the head like this, it is a sternocleidomastoid over here which is helping in that. So that is a specific symptom due to paralysis of sternocleidomastoid. And a combination of this is spinal accessory. So now you know the answer over here according to the question. According to the question is trapezius. Okay, according to the question. So there were three options which were correct answer, but we have understood what is the right answer, trapezius. Now let us see this question over here. Okay, that's great. Yes, when the sternocleidomastoid is gone, there is difficulty in turning the head because the patient will not be able to turn the head or difficulty in turning the head. Now, next question is what? A patient has normal extension at elbow. Normal extension at elbow. Now, when you see this question and when you see the options over here, you know that it is a upper limb question, upper limb nerve injury question, right? And when you are seeing the upper limb nerve injury question, you should think about the deformities. Ulnar nerve, then the partial claw hand is mentioned. If I say median nerve, they will be mentioning either the ape thumb deformity or the benediction deformity. When you say radial nerve, they will be talking about the wrist drop. So this thing should be in your mind. And now when I say normal extension at elbow, then weak extension at wrist, and this is and along with or and loss of extension at fingers. Now when you see this specific symptom, this is finger drop. Now what you see over here is as yes, very, very correct. I can see a lot of you are trying to answer A. Yes, there is always a confusion between A and C. So you should be able to tell the answer over here because these all three are the components of radial nerve. So you should be able to decide between the three. And yes, of course, the answer over here is posterior introitious nerve. We will discuss about it. Now what is this? Finger drop. The rest of the things are normal. The normal extension at elbow. At the wrist, weak extension is possible. So no, the complete wrist drop is not there. No sensory loss is there. So now whenever you are talking about the radial nerve, you should be knowing the radial nerve from the axilla goes into the spiral groove. Then it reaches the lateral epicondyle of humerus, where it divides into two branches, superficial branch, completely sensory. Deep branch, which is also known as posterior introitious nerve, motor branch. Okay, so that means if this nerve is gone, only the sensory loss. If posterior introitious nerve is gone, the motor loss will be there and no sensory loss will be there. Fine. Now when the lesion is at higher up area, axilla, you are having all the symptoms. As the lesion is going downwards, the symptoms, one symptom will reduce. So at the spiral groove, we are having these three symptoms, wrist drop, finger drop, along with the sensory loss. And now when the lesion level is going more downwards, that is at the level of elbow. So when there is lateral epicondyle fracture, so two specific symptoms we are having, finger drop and sensory loss. Wrist drop is not complete because weak extension is possible at the wrist. And another thing what you see over here is if the question is specifically on posterior introitious nerve injury, then typically one symptom is there and the rest of the things are normal. तो जब भी आप क्वेश्चन पढ़ो, अगर आपको लगे कि सब कुछ नॉर्मल लिखा हुआ है, सब कुछ ये नॉर्मल है, तो प्रॉब्लम क्या है? सिर्फ एक प्रॉब्लम होगी फिंगर ड्रॉप. And if only one symptom, finger drop, is there, the rest of things are normal. Quickly you should say specific answer is posterior introitious nerve, which is a branch of radial nerve. So if you have to decide between radial nerve and posterior introitious nerve, over here is more specific answer is posterior introitious nerve. And now you know radial nerve, superficial branch is only sensory branch, so only sensory loss. So therefore the answer over here is posterior introitious nerve. Yes, very correct. Yes. Okay, now let us move further. So keep the faith, keep working hard, great things will happen. So have faith in yourself, believe yourself. अपने ऊपर आपको थोड़ा सा विश्वास रखना पड़ेगा, थोड़ा नहीं बहुत विश्वास रखना पड़ेगा, because whenever you are giving the exam, it is only you who will be with you. सिर्फ आप ही होंगे जो आपके साथ होगा कौन उस समय, आपके साथ सिर्फ आप होगे, आपका ब्रेन होगा, आपकी जो भी उस समय जो भी आप फील कर रहे हो वो सारी चीजें सिर्फ आपकी होंगी. So believe yourself and tell yourself, yes, I will be able to do it, and keep working hard, because that is the only thing which you can do. हार्ड वर्क करना आपके हाथ में है, बाकी सब चीजें भगवान पे छोड़ दो, बाकी सब चीजें आप साइड में रख दो. आप क्या कर सकते हो, आप कर सकते हो हार्ड वर्क, आप कर सकते हो पढ़ाई. इस टाइम पे एक ही चीज कर सकते हो, पढ़ाई, एंड दैट यू हैव टू डू. सो हैव फेथ इन योरसेल्फ. नाउ गोइंग टू द नेक्स्ट क्वेश्चन. I've included this question because this is a very, very important question, and over here we will be discussing this point, and along with that we will be also discussing that what arteries are arising from which arch, because this is very, very important point. So I have included this. Yes, wow, so nice of you. आपकी voice होगी मैम, very nice of you, हरिओम. सबकी, इनफैक्ट सारी फैकल्टीज जिनसे आपने पढ़ा है वो सब आपको एकदम फ्लैशबैक आएगा कि अरे सर ने ये बताया था, मैम ने ये बताया था. सो एवरीबॉडी वुड बी फ्लैशिंग बैक ओवर देयर. वाओ वाओ, AK-47 सर की, अमित सर की, वेरी करेक्ट. Okay, so I can see you are trying to answer this question. Yes, 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 yes. Left sixth arch. Option D. Now, when you see this defect which has been shown over here, the arrow is actually put over here. And when you see this arrow over here, which is between this pulmonary trunk and the arch of aorta, what is this defect? It is actually the ductus arteriosus. Over here, they are actually, this is what? This is the persistence of the ductus arteriosus, or we say this communication over here, it is ductus arteriosus. And when we specifically say that it is derived from which aortic arch, then we say it is from sixth arch, and specifically left side. So the answer over here for this is left sixth arch. Now over here only you should be knowing that when we are talking about these aortic arches, actually the aortic arch from respective pharyngeal arches. So we very well know that when we are talking about the first arch, it is forming which artery? Maxillary artery. When you say second arch, it is stapedial artery. When you say third arch, it is carotid arteries. All the carotid arteries are common, external, internal. When you say fourth arch, in the fourth arch specifically I will write only for the left because it is very, very important. Arch of aorta. And when you say sixth again, it is actually forming the pulmonary arteries. The sixth is forming the pulmonary arteries, and specifically on the left side it is forming ductus arteriosus, which we have mentioned over here. So for the fourth as well as sixth, more they ask about left side. For the fourth arch on the left side it is arch of aorta, and for the sixth arch on the left side specifically forming the ductus arteriosus, along with the pulmonary arteries which it is forming. For the fourth arch, if you say that, ma'am, what is on the right side? So right side is the subclavian artery, the right subclavian. Okay, but these are very, very important, which I have written over here. These are the arteries derived from each of the arch, and now you know that the answer over here is the sixth arch. Yes. Okay, now let us go to this another question, which is a high yield question, diaphragm. Now the diaphragm is a question which is another high yield topic, and already we have discussed the major openings of the diaphragm in some other question, where we discuss the major openings and what is passing through the major openings. Over here we will be discussing the development, plus we will be also mentioning the locations of opening. Okay, now when you see this image, let us first of all identify A, B, C, D. Now when you see this image, this is the anterior side, this is the posterior side. Why posterior side? Because over here you can see the vertebra has been shown. Okay, this is the vertebra, so that is why this is the posterior side. Try to answer this question. Till then we will discuss over here. When you say C structure, C is what? C is septum transversum. Okay, C is septum transversum, D is pleuroperitoneal membrane. When I talk about B, it is dorsal mesentery of esophagus. It is the dorsal mesentery of esophagus. And if you say what is A, it is a lateral body wall mesoderm. So over here we have mentioned all, yes, very correct. Over here we have mentioned all A, B, C, D. And now let us see the question B. First of all, what is it? All the statements are correct except. Okay, so now you know that you have to see which is all are correct except. First of all, B. B is what? Dorsal mesentery of esophagus. Yes, the dorsal mesentery of esophagus, it forms crust of diaphragm. Okay, this was the question which was asked recently in the January this year only, that which component is forming the crust of diaphragm. So now you know it is a dorsal mesentery of esophagus which is forming the crust of diaphragm. This is correct. C. C is what? Septum transversum, forming the central tendon. Yes, this is also correct. So now you know these 2 points which are specifically asked. Either they ask about the crust formed by dorsal mesentery, or they ask about the central tendon formed by septum transversum. C. Now you know that this area is going to form central tendon. So now we say next option is C. C is having which opening of the diaphragm? So this is what side? This is the anterior side. This is not the location for aortic opening. This is not the location for aortic opening. The location, this is a location actually for vena cava opening. Then next is D, 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 D. Yes, this one is D, which is correct. It is pleuroperitoneal membrane. So now whenever you are seeing this question, when you decide when you decide anterior and the posterior side, the majority of the area on the anterior side is septum transversum, and on the posterior side, the rest of the area is what? Pleuroperitoneal membrane. Okay, then this projection on the posterior side is dorsal mesentery of esophagus. Lateral side contribution is lateral body wall mesoderm. Now after this, when you say openings, so you very well know that the openings of the major openings of diaphragm is, this is vena cava opening, this is the location of esophageal opening, and this is the location of aortic opening, right? And when you see from anterior to posterior side, so now you know the location over here. This is central tendon. So in the central tendon, this whitish area, what you are having? You are having what? Vena cava opening. Then as you talk about the esophageal opening, the esophageal opening is in muscular part of diaphragm. And when you talk about aortic opening, the aortic opening is between the two crusts, right and the left crust, or you can say it is behind this ligament. What ligament? Median arcuate ligament. Okay, it is behind the median arcuate ligament. So for the aortic opening, behind this median arcuate, or we say between the two crusts. So this is the specific location for these openings. And last year the question has been asked on aortic opening, that what is passing through it. So that we have already discussed. You should be able to identify all the openings in this image. Right. So over here, now we know that when we are talking about the central tendon, it is a vena cava opening which is opening over here, and therefore the answer of this question is what? The answer of this question is C, right? The answer of this question is C. Yes, VOA, Voice of America, and the vertebral level is 8, 10, 12. It is T8, T10, T12. Very correct. Voice of America. Now let us go to the next question. Now this question is an easy question, but it will be checking the multiple things. And I hope that you are able to answer it correctly. This is a scorer for you. You should not do any error in this. It is checking that if you are able to identify the muscles, and the next thing it is checking that are you able to tell the action. And if you see what is not correct. Okay, what is not correct over here? So try to answer over here. So dear, for the time management now, because you know the sections are there for each of the paper. So for the time management plays an important role at this time. Whenever you are doing the question, whenever you see the question, try to attempt in that go only. And see, you have to see that you are able to attempt all the questions in time. So for that, what you will do is that from now only you start practicing by putting a timer. That is a good way to practice or good way for time management. Whenever you are doing the MCQs, do the MCQs together, like put a timer for half an hour and just keep doing the MCQs and observe that how much MCQs you are able to do. Or you can do what? You can do 100 questions in one go and set a timer, and when you do the 100 questions, after that see that how much time you are taking. So that is how you are going to manage the time, and this is how you will learn to manage the time, because this is very, very important in this upcoming exam. Okay, yes. Now over here I can see two options, C and D. So first of all, let us try to identify the muscle. When you see, this is of course a posterior aspect of the back of the chest area, posterior aspect. When you see this area, this is the scapula. This is what? Yes, this is the spine of scapula. This is spine of scapula, and you know muscle above the spine of scapula, supraspinatus. Muscle below the scapula, spine of scapula, it is infraspinatus. So above the spine of scapula, supra, below it is infra. This is the spine of scapula, right? Now another muscle which you see, C. C is the muscles which is between the vertebral column and scapula. So what is this muscle? This is one muscle, second muscle, third muscle. What are these? This is levator scapulae, this is rhomboid minor, and this bigger one is rhomboid major. These three muscles which are arranged together over here, and therefore we say C is rhomboideus major. This is a rhomboideus major. Okay, so we have identified A, B and C, and now let us read the question. Option B. Option B means infraspinatus, helps in lateral rotation of shoulder. Yes, whenever you are talking about the lateral rotation of the shoulder joint, for the lateral rotation of shoulder joint, there are two muscles helping in that. One is infraspinatus and another is teres minor. So you can say the smaller muscles, the smaller muscle, like infra is lower muscle and minor is smaller muscle. So these two small muscles or two muscles, they are helping in the lateral rotation. So this point is correct. A, supraspinatus, helps in abduction of shoulder joint. Yes, this is also correct because it is helping in the 0 to 15 degree of abduction at the shoulder. So 0 to 15 degree by supraspinatus, 15 to 90 degree deltoid, and overhead abduction means above 90 degree is by trapezius and serratus anterior. So yes, it is helping in the abduction of shoulder 0 to 15. C is rhomboideus major, helps in retraction of scapula. Yes, very correct. Both the rhomboideus minor and major, they are helping in the retraction of the scapula. Protraction of the scapula is done by serratus anterior. So what is the retraction? Retraction is scapula going towards a vertebral column or moving towards a midline. Okay. So retraction of scapula, yes, it is correct. And now the next is C has same action as, not the upper fibers, it has same action as middle fibers of trapezius. The middle fibers of trapezius, they also help in retraction. It also helps in retraction. So over here, this is not correct. And whenever we are talking about the trapezius, upper fibers, when you say trapezius, the upper fibers, they help in elevation of scapula. Lower fibers, they help in depression of scapula, and the middle fibers over here, they help in retraction of the scapula. Okay, so now we know that answer of this question will be what? Yes, the answer of this question is this one. And let us identify all the muscles over here. Okay, yes, very correct. Yeah, triple P for, this was actually for serratus. Okay, very, very thanks to Ashish. Now, when you see this image over here, you are able to identify all the muscles. We have identified already this supra and infra. And now another muscle we should be able to identify over here is this one and this one. When you say this is teres minor and towards this lower side, this is the teres major. Okay, teres minor and major. Already we have identified these three muscles. We already identified this one, that this is the trapezius, and now another muscle over here is lower side muscle. What is this? This is the latissimus dorsi. This is the latissimus dorsi. So you should be able to identify all the muscles over here. So we have identified all the muscles over here. Very correct, very correct. So now moving on to the next question. Yes. Now this is again a question which is a high yield topic, and if you read the question, what is the question? A patient has presented with decreased secretions from what? Submandibular and sublingual gland. Okay, there is a decreased secretion of submandibular and sublingual gland along with loss of taste sensation from anterior part of the tongue. So now what do you see? The key word is this one. This is the keyword which will take you to the answer. Loss of what? Taste sensation. Which area? Anterior part of the tongue. So now you will be able to answer over here. What will be the answer? What can be the answer of this question? When we are talking about the taste sensation, I will wait for that so that you try to answer it. Yes, very correct. C. It is chorda tympani nerve. It is, the answer over here is chorda tympani. So let us see over here when we are talking about the sensation which is carried over here. The anterior two-third part of tongue, the general sensation by lingual nerve and the taste sensation by chorda tympani nerve. Already the question has been asked on lingual nerve, and very much we expect now that the question can come on chorda tympani nerve. Now apart from that, the posterior one-third, both general and taste sensation by glossopharyngeal. Posterior most part of tongue, both general and the taste sensation by vagus nerve. And when you talk about this hypoglossal nerve, it is actually for muscles. It is supplying the muscles of tongue. So this is for the motor supply. It supplies all the muscles of tongue except the palatoglossus. So hypoglossal nerve is for the muscles or for the motor supply. Yes, very correct. So now when I say this is for the muscle, so we can exclude it. The lingual nerve is for general sensation. Okay, this is for the general sensation, and this is for posterior one-third. So when I say anterior part means anterior two-third only, of course. The answer will be chorda tympani. And another thing which is happening over here is that decreased secretion of these glands. Why? Because if you remember, parasympathetic ganglia. Okay, though we have reached the answer, we have understood that how the answer is there, we have reached the answer according to this key point. But if you say that why ma'am this symptom is there, so for that when you say parasympathetic ganglia, you are having submandibular ganglia which is functionally related to cranial nerve 7, and which specific branch of cranial nerve 7? It is chorda tympani nerve. And the submandibular ganglia, it supplies the same named gland, submandibular gland and sublingual gland. So now over here, because the chorda tympani is affected, it is affecting the secretions of what? Submandibular gland as well as sublingual gland. So this is just an explanation of this symptom, but otherwise you can quickly answer according to this keyword. Yes, 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 very correct, very correct. Now let us go to the next question, last question over here, the last question for the today's session. So I hope that whatever questions we have discussed today are really helpful to you. Whatever knowledge you have gained till now, it is helping you to, manage that knowledge and to apply that knowledge in the questions. You have also understood that how the questions can be asked, what the trick can be there, what twist can be there, and you may have learned some new points also today. So I hope that this session is very useful for you for this upcoming exam. And now when you see this question, what is the adult remnant of arrow mark structure? Now when you see, this is the lateral view over here, of the developing embryo. And when you see, this is a location of the umbilicus. You can say this is a location of the umbilicus. Yes, I can see a lot of you answering the question. Now, when you see this structure, the arrow marked structure, I will tell you it is allantois. Okay, when you see this arrow marked structure, what do you see? The arrow marked structure is coming from here. And what is this? This is hindgut. And in the hindgut also specifically it is cloaca. So the cloaca is having the attachment to a duct, allantois, which is going towards this umbilicus side, and the arrow mark structure is allantois. Now the twist is that you have to answer its adult remnant. So now when you are talking about the adult remnant of this allantois structure, so this is the allantois, its adult remnant is given the term as urachus, and it is also given the term as median. Okay, the word over here is median, median umbilical ligament. So this is for allantois. This is the adult remnant of allantois, urachus or this median umbilical ligament. And now if you say that, ma'am, what about the other options? So we have understood the arrow mark structure, the allantois, the answer is median umbilical ligament. So what about the others? When you say nucleus pulposus, this is the adult remnant of notochord. Notochord, adult remnant of notochord. Nucleus pulposus of intervertebral disc. Now if you say ligamentum teres hepatis, that's great that you are finding anatomy easy, Dr. Sachin. So that's so nice to hear. Now next option is ligamentum teres hepatis. Now for this we say it is the adult remnant of umbilical vein. It is the adult remnant of umbilical vein, ligamentum teres hepatis. Now the lateral umbilical ligament is no structure, but actually one more structure is there. What is that? Medial umbilical ligament. Now if you see, the word over here is medial. It is different from the earlier word, median. This is median. Another word I am mentioning over here, medial. And what is this? This is actually the adult remnant of umbilical artery. Okay, this is actually what? Distal part of umbilical artery. The distal part of umbilical artery, it obliterates to form the adult remnant. We know it is forming the umbilical ligament. Which umbilical ligament? Medial umbilical ligament. So over here we have mentioned all these points and the two confusing points also. So you should be knowing the medial is for the umbilical artery and the median one is for urachus. Okay, this is for the one allantois or urachus. So that's okay. So thanks to all of you that you are finding this session helpful, and of course best wishes to all of you, good luck to all of you. As I just kept repeating this, that have faith in yourself and work hard. Always be optimistic, never give up, and you will surely reach your destination. And in the end of the session, please take away word is persistence. You have to persist whatever is the situation, whatever may be the situation, but you have to persist. आपको बीच में से रास्ता छोड़ के नहीं भागना है. मतलब कहने का मतलब है कि जो भी आप प्रिपरेशन कर रहे हो उसमें आपको, चाहे आपका मन लग रहा है, मन नहीं लग रहा, याद उतना ज़्यादा नहीं हो रहा, थोड़ा थोड़ा हो रहा है, कोई भी सिचुएशन है, या फिर आप थोड़ा सा एंग्जाइटी में हो, कोई भी सिचुएशन है, आपको पढ़ना है, परसिस्ट करना है. अनदर थिंग, अनदर टेक अवे वर्ड इज बी पॉजिटिव, पॉजिटिविटी. दीज टू things are very, very important in these last days of preparation. You have to be positive, avoid distractions, avoid negative talks, avoid negative distractions, stick to one source. That is very, very important. And yeah, stick to one source, very, very important. And these are the two main keywords over here. So by this we have completed the 25 important questions, and I really hope that it is very helpful. And yes, we will be having a image rapid revision session also, which will be after few days, and you will be told that when it is there. But we will be having a small session for images also, which will be a separate session. And So I'm ending the session over here. Yeah, that's great. For the management tips for the upcoming days, yes, you can see, watch the 45 days session which we have taken, and then before the exam also we will be having some session for the tips which will be for the day of the exam. Okay, so by this I end the session over here, and best wishes, best of luck to all of you. Keep doing well.